The subcommittee will come to order. Welcome to the Ways and Means Health Subcommittee hearing on lowering costs and expanding access to health care through consumer-directed health plans. It's my pleasure to welcome our four witnesses today as we continue our discussion on lowering health care costs and increasing access to affordable insurance options. Health care reform should empower individuals and families to make decisions for themselves based on what fits their needs and their budget. One of the best tools we have to accomplish this goal is consumer-directed health plans that are paired with health savings accounts, or HSAs. These plans offer lower premiums and a higher deductible to encourage better use of health care services. Engaging consumers in their health care spending is critical to reining in our system's ever-increasing costs. These plans continue to increase in popularity, now covering more than 21.8 million Americans. Today, our panel will update us on how health savings accounts are working for American families and employers. We're going to hear interesting data on current enrollment trends and demographic information on millions of people enrolled in HSAs and other tax-preferred savings accounts. We'll also discuss many benefits of consumer-directed health plans and their potential costs to lower overall costs. I'm also pleased to hear what role these plans can play in fostering more price transparency, something that we all have been discussing for quite some time. In addition, our witnesses will tell us about the barriers employers and individuals face when trying to offer or enroll in an HSA qualified plan. And finally, we'll examine the various reform ideas, including many authored by members of this subcommittee, that are aimed at expanding access to HSAs. Our goal is to use this hearing as an opportunity to discuss how we can give more people this affordable option for coverage while still preserving the right structural incentives to bend the cost curve and keep premiums low. I appreciate the knowledgeable testimonies of the witnesses here today, and this subcommittee looks forward to hearing comments, criticisms, and observations on how to flesh out the details of how best to improve HSAs through this hearing. Now I yield to Mr. Thompson for the purpose of an opening statement.
Thank you, Mr. Chairman. Thank you for holding the hearing, and thanks to the witnesses for being here today. As it stands today, high-deductible health plans and the health savings accounts that accompany them plug a gap in the market. They offer employers a lower-cost alternative amid ever-climbing large and small group coverage rates and give patients a hand in making out-of-pocket payments. These plans are a reflection of a healthcare market where costs growth continues to place quality care out of reach for far too many people. Health spending grows at more than 2 times the rate of inflation. In the employer market, this is a direct result of the cost of care, including factors such as prescription drugs or hospital inpatient stays. No one player in the healthcare industry is without some responsibility for these increasing costs. As policymakers, our reaction must not be to incentivize the shift of those costs to consumers. It's not a cost containment solution, it's a cop-out. It doesn't address the root of the problem. It's not sustainable, and it doesn't help the people that we represent. Because forcing patients to feel the pain of their care costs doesn't necessarily lead patients to make those to choose treatments that drive the best possible outcomes. At the end of the day, patients are not expert consumers of health care, and simply exposing them to high prices doesn't change their understanding of the value of a treatment. What gets them the most bang for their buck? That's in large part because they may not have a choice given the consolidation or provider affiliations, or they simply don't have the time, expertise, nor information to become truly well-informed. In California, for example, hospitals report charges for their 25 most common outpatient procedures, but that information isn't standardized or audited for accuracy. California Healthcare Compare, the state's online tool for consumers to compare price and quality, offers only that information which insurers and providers have elected to share. Options that look appropriate based on the site's information may not even be in the patient's high-deductible health plans network. And for the quarter of consumers enrolled in high-deductible health plans, all the information in the world isn't going to help them meet their deductible when they have no HSA and their out-of-pocket costs are simply unaffordable. From our witnesses today, we can learn more about the technical aspects of these plans, how we remedy unintended consequences of existing policies, and the impact of changes like those sought by members of our committee on a bipartisan basis. But we should be under no false impression that such change will provide our constituents with meaningful relief from the type of health care bills that leave them deciding between rent and critical care. This committee has more work to do to address growing health care costs, and I look forward to working with my colleagues to develop and improve policies set forth under the ACA to bend the cost curve over the long term. Mr. Chairman, is now the appropriate time for me to introduce the Democratic witness?
Not quite yet, but it's coming soon.
But you will let me know.
Yes, sir.
All right, thank you. I yield back.
Thank you, Mr. Thompson. Without objection, any member's opening statements will be made part of the record. We'll hear from our witnesses. Let me briefly introduce three of them, and then I'll yield to Mr. Thompson. First, we'll hear from Roy Ramthan, who is the president and founder of Ask Mr. HSA Services, who will give us an account and basically an overview of the creation of HSAs and explain the benefits of consumer-directed health care and why access to these accounts should be expanded. Next, we'll hear from Matt Isles, the president and CEO of AHIP, America's Health Insurance Plans, who will update us on the enrollment trends and demographics of account holders, and his testimony is going to highlight some of the experience of HSAs in the individual market, including the exchanges and how HSAs can offer lower costs for middle-income Americans. Then we'll hear from Jody Dietl, who is the Chief Compliance Officer at WageWorks, who's going to present data that will inform us about who will be benefiting from HSAs today. In addition, she'll give us insight on the barriers that employers are facing when they try to offer these plans. And now I yield to Mr. Thompson for the introduction of our final witness.
Thank you, Mr. Chairman, and thank you, Dr. Sherry Gleed, for being with us today. Dr. Gleed currently serves as the Dean of New York University's Robert F. Wagner Graduate School of Public Service. Prior to her work in academia, Dr. Gleed served as the Assistant Secretary for Planning and Evaluation at HHS, and she was a member of the President's Council of Economic Advisors. As an expert on the intersection of healthcare and economics, Dr. Gleed can provide our committee with valuable insight on how we can most effectively address cost and affordability in the context of consumer-directed accounts. Dr. Gleed, thank you for being with us.
Thank you all for being with us today. As I explained in a little pregame a moment ago, each of you have 5 minutes. Your written testimony is a part of the record, and this committee's familiar with it. Then we'll invite members to inquire, and an old trick is for members to talk for about 4.5 minutes and then use 15 seconds to pose a question and then give you 5 seconds to answer. So we'll try and resist that temptation today, and Mr. Ramtham, we'll start with you. You're recognized.
Thank you, Chairman Roscom, Ranking Member Levin, and members of the subcommittee. I thank you for this opportunity to testify before you today. My name is Roy Ramthan, and I led the implementation of the HSA program after its its enactment in 2003 while serving at the U.S. Treasury Department. A few years later, I started my own consulting practice to devote my full time and attention to this program and related issues. The HSA market is currently dominated by employer-sponsored coverage, with over 80% of the enrollment coming from large employers. Employee enrollment in high-deductible health plans has doubled over the past 6 years, with approximately 30% of employees now being enrolled in these plans, many of whom have HSAs. I expect these trends to continue as long as premiums increase faster than inflation and the ACA's Cadillac plan tax looms in the future. In contrast, the individual market was originally the largest source of HSAs, but over time has fallen to under 10% of all participants. HSA plans have been available on the state health insurance exchanges since 2014, primarily as bronze and silver plans. But as with the rest of the individual market, carrier exits and reduced product offerings have limited HSA plan choices more recently. Regardless of market segment, it seems as if every plan is a high-deductible plan today. But not all plans with high deductibles make individuals eligible for HSAs. Recent data from the National Center for Health Statistics indicates that approximately 43% of working-age adults are enrolled in high-deductible health plans. but only about 18% are enrolled in an HSA-qualified plan, leaving the other 25% without access to an HSA. As a result, millions of Americans face similar exposure to out-of-pocket costs but cannot use an HSA to protect them. HSAs could be a part of the solution to this problem. HSAs require no guesswork and no reason to fear losing the money that is not spent each year. In fact, most people could save money simply by adding up all their qualified health expenses at the end of the year and reimbursing them through their HSA. There are numerous legislative proposals to modify HSAs pending before the Ways and Means Committee, including bills introduced by members of this subcommittee. In particular, I would like to acknowledge the leadership of Representative Eric Paulson, who has sponsored the Health Savings Act for the past several Congresses. The HSA industry still considers this bill the gold standard for HSA legislation. I have summarized and categorized the legislation as part of my written testimony for your review. I believe the simplest way to allow more Americans to access HSAs is to move to a more flexible health plan design based on actuarial value. Actuarial value tells us how generous a plan's benefit design is based on its deductibles, co-pays, co-insurance, and annual out-of-pocket limits. For example, an actuarial value of 90% indicates that a plan is designed to cover 90% of the benefit costs on average, leaving 10% to be paid out of pocket by the enrollees. Since deductibles and out-of-pocket limits have the greatest impact on actuarial value, plans with lower deductibles and lower out-of-pocket limits typically have higher actuarial values. Actuarial value could become an alternative way of determining HSA eligibility. I recommend that health plans with actuarial values below 80% also make consumers eligible for HSAs. I believe 80% is a reasonable standard because HSA-qualified plans can currently be offered in the gold medal tier on the state insurance exchanges, and I also believe employer-sponsored coverage is close to 80% currently. I hope you will consider this proposal as you contemplate making changes to HSAs. In conclusion, I support expanding HSAs to more Americans to help them with their growing out-of-pocket costs. I also support expanding contribution limits for HSAs so that everyone has the opportunity to cover their full risk for out-of-pocket expenses through their HSA. This would especially help Americans with chronic conditions and high medical bills. Mr. Chairman and members of the subcommittee, I appreciate the opportunity to provide this testimony today. I look forward to discussing these issues in greater detail with you, and I would be pleased to answer any questions you have. Thank you.
Thank you. Mr. Isles.
Chairman Roscom, Congressman Thompson, and members of the subcommittee, I'm Matt Isles, President and CEO of America's Health Insurance Plans. I appreciate this opportunity to testify on consumer-driven health plans and their role in providing Americans with access to high-quality, affordable health care coverage. Many AHIP members offer health insurance coverage that can be combined with health savings accounts. This is one of many options that health insurance providers offer to give consumers better choice, control, and affordability. Millions of Americans have found this innovative combination of a tax-free savings account with insurance coverage to be an appealing option for meeting their health care needs. Our written testimony focuses on three main areas. First, some background information on HSAs, including the findings of an annual AHIP survey that has measured strong enrollment growth in HSA-eligible plans over the past 12 years, measuring over 2,000% increase in enrollment over this period. Second, key issues for policymakers to consider while examining the current status and future role of HSAs and HSA-eligible plans. And third, some proposals to strengthen and improve HSA and HSA-eligible plans to better empower consumers to meet their personal needs. Since 2005, AHIP has conducted an annual survey on enrollment in HSA-eligible plans. Our most recent survey from April 2018 shows that enrollment in HSA-eligible plans totaled nearly 22 million as of January 2017, more than a 9% increase over the previous year. For context, there are now more Americans currently enrolled in HSA-eligible plans than in the entire Medicare Advantage program. The dramatic growth in enrollment is because of the real value that HSA plans deliver: consumer choice, patient control, and the opportunity for individuals to use tax-free funds to pay current medical expenses while also setting aside money for future health care costs. According to our survey results, the vast majority of HSA-eligible plans offer consumers the tools and technology to enable them to make informed decisions and spend their healthcare dollars wisely. Across markets, these resources are imperative to ensure that those enrolled in HSA-eligible plans are informed about the best way to use their funds to meet their current and future needs. Tens of millions of consumers know the value that HSAs deliver every day, but we also know there's room for improvement. Since their enactment, there have been few changes to HSAs, even as other areas of the healthcare system have experienced vast transformation, as we have learned lessons from the utilization of these accounts that has grown. This includes a revolution in healthcare technology, a shift from volume-based to value-based payments, and a growing recognition that covering high-value services can help reduce long-term costs and improve outcomes. At the same time, healthcare costs have grown substantially for health services and treatments, especially prescription drugs, making it even more imperative that consumers have more choices and more control over their healthcare dollars. Our testimony outlines a few solutions to make both HSAs and HSA-eligible plans even more effective and valuable options. These solutions focus broadly on three priorities. Number one, allowing greater benefit design flexibility for HSA-eligible plans. Specifically, HSA-eligible plans should be allowed to provide pre-deductible coverage for services that help Americans manage their chronic conditions just as they do for preventive care. This would improve the value of HSA-eligible plans for consumers and enable patients to more easily access care they need to effectively manage their health, potentially avoiding debilitating and costly complications. Number two, increasing flexibility for HSA contributions and how these funds are used. The maximum HSA contribution limit should be increased to align with the maximum out-of-pocket expenditure limits that apply to HSA-eligible plans. We believe that consumers should also be allowed to use HSA funds to easily pay for over-the-counter drugs and services and products that improve health, such as telemedicine consultations and other supplemental benefits. Third and finally, improving healthcare affordability. It's critical, particularly for the middle class and self-employed, and to allow more consumers to fully utilize consumer-directed health products. This can be accomplished in a few ways. These include aligning the out-of-pocket thresholds with actuarial value meta levels for consumer-directed plans in the individual and small group markets, clearly indicating HSA eligibility for exchange policies, allowing adult dependents to use HSAs, promoting HSA literacy, and finally, building off recent successes in the states by exploring novel ways to increase access to consumer-directed health products. Thank you for the opportunity to discuss the value of HSAs and HSA-eligible plans. Like you, we're committed to strengthening, supporting, and improving this important and increasingly popular healthcare option. We look forward to working with you to advance solutions to deliver affordable access to high-quality coverage and care for every American. Thank you.
Thank you. Ms. Dietl.
Thank you, Chairman Roskin, Ranking Member Levin, and members of the subcommittee. My name is Jody Dietl, and I'm the Chief Compliance Officer for WageWorks Incorporated, a leading provider of consumer-directed benefit accounts, including health savings accounts, health reimbursement arrangements, and health flexible spending accounts. WageWorks administers consumer-directed plans for about 85,000 employers across the nation, including the FSA Feds program. Our services cover more than 7 million employees, most of whom participate in a health FSA or health savings account. Due to the nature of our administrative services and our diverse client base, we have access to significant and compelling data which we monitor and analyze on a regular basis to help improve our services. Let me share some highlights of our data with you. Many people assume that HSAs are used primarily by highly paid employees. Our data shows this to be incorrect. The median household income for an HSA account holder in our book of business is $56,100. It's rapidly declined over the last few years as HSAs have become far more prevalent. Additionally, nearly 77% of those contributing to HSAs in our book of business were born after 1965, belonging to the Gen Z, Millennial, and Gen X demographic. Only about 22% of our participants are baby boomers. People also assume that individuals stuff large amounts of money into their HSAs. However, our data shows consistent average annual contributions over time, ranging from a low of just over $1,000 in 2010 to a high of $1,500 in 2017. With annual statutory contribution limits ranging from $2,900 to $6,760, depending on coverage level, this contribution data defies the notion that employees are using HSAs for means other than funding their medical expenses. In fact, HSA account holders in our book are largely spending their fund balances. Our data shows that over the last 7 years, amounts ranging from just 25 to 35% of annual contributions are carried into the next year for future out-of-pocket expenses. 66% of transactions and nearly 70% of spending is on inpatient and outpatient medical care, and 33% of the transactions and about 13% of dollars spent are spent on prescription drugs. As members of this committee know, employers are faced with increasing health plan design challenges in their quest to contain costs while maintaining a healthy and productive workforce. One example of an unnecessary hurdle is the existing HSA eligibility rules. These limit employers' ability to offer value-based insurance designs which can help pay for specified chronic disease services, improve treatment adherence, and condition management. Employers are also largely prevented from offering certain telemedicine services or access to near-site or on-site clinics while also maintaining an employee's eligibility to contribute to an HSA. Other design challenges include the ability of a working senior or an individual covered by Indian Tribal Health Services or TRICARE to contribute to an HSA. Also, an employee whose spouse may have a health FSA is prevented from contributing to an HSA even though they're covered by a qualified high-deductible plan. Outside data indicates that an increasing number of employers are moving to high-deductible health plans, and this trend only increases the important role of HSAs. Another major challenge for employers is the Cadillac tax. While delayed until 2022, which we thank you for, this excise tax still looms large. As currently enacted, it appears that employee contributions to HSAs and health FSAs are included in the calculation of the tax. To keep costs below the threshold, employers may have no other choice but to limit the amount employees may contribute to their HSA or health FSA, which ends up hurting employees who need help paying for their out-of-pocket costs. It's important to know that health FSAs are also valuable tools for working Americans because FSA funds are available on day one rather than needing funds to accumulate before reimbursing expenses. FSAs can be designed to coordinate with health savings accounts, paying for dental and vision expenses while allowing the HSA to pay for out-of-pocket costs. WageWorks recognizes the opportunity Congress has to enact meaningful HSA policy changes, and we'd like to serve as a continued resource in that endeavor. Thank you for inviting me here today, and I look forward to answering any questions that you may have.
Thank you. Ms. Gleed.
Chairman Roskin, Ranking Member Levin. There you go. Chairman Roskin, Ranking Member Levin, and members of the subcommittee. I am Sherry Gleed, Professor and Dean of the Robert F. Wagner Graduate School of Public Service at New York University. Thank you for inviting me to testify. The U.S. healthcare system is in much better shape today than it was 10 years ago. The uninsurance rate has fallen by nearly half. The rate of growth of healthcare spending is at historic lows. But there is increasing concern about maintaining the affordability of healthcare. That's because although many more Americans are insured today, there have been changes in the nature of coverage. High-deductible health plans not only continue to dominate the non-group health insurance market, as they always have, but they now make up nearly half the plans offered to employees. Analyses by the Federal Reserve Board, however, show that over 1/3 of all American adults don't have enough income and savings to shoulder an unexpected emergency bill of just $400, well below the deductible in a high-deductible plan. That low level of financial security is on a collision course with this rise in high deductibles. HSAs offer a tax break, that is a tax expenditure, to people who have specialized savings accounts. Relaxing the rules on HSAs would make that HSA tax break and expenditure bigger. But would increasing those tax breaks be a good way to allocate scarce public resources toward addressing the affordability problems that are of growing concern to many Americans? A robust body of evidence says the answer is no. Relaxing HSA rules in general would not be a cost-effective way to address these concerns. One critical reason is that there is a mismatch between those who would gain from HSA tax breaks and those who actually need the financial protection. It's lower middle income Americans who face real problems paying medical bills. But people with incomes in this range face very low marginal tax rates, and that means that they gain very few benefits from the tax breaks afforded to health savings accounts. Instead, those tax breaks are most valuable to people in the highest marginal tax brackets. And in that group, very few people have difficulty paying medical bills. So every extra dollar of tax expenditures devoted to HSAs buys very little gain in healthcare affordability. As we'd expect, higher income people are more than 4 times as likely to open HSAs and to fully fund them than are those with lower incomes. Because of those patterns, we find that for lower middle income households in high deductible plans, whether you have an HSA or not has absolutely no effect on whether you can afford to pay your medical bills. Another problem is that we now know that the basic idea here, to encourage smarter consumption of healthcare through consumer-directed health plans, while theoretically elegant, is flawed in practice. Most people do not treat their HSAs as savings vehicles. They don't accumulate money in them. Instead, for people who are relatively healthy and who don't anticipate using a lot of services, the tax break for HSAs effectively reduces the first dollar cost of care. It undoes the effect of the deductible. Expanding the scope of HSAs would just give healthy, higher-income Americans, the ones who put money into their plans, even bigger discounts on a broad range of discretionary medical services like over-the-counter drugs and prescription sunglasses. It also turns out that having a consumer-directed plan does not make people smarter consumers. People with consumer-directed health plans spend more on expenses that aren't covered by health insurance at all, like those sunglasses, but they also use fewer preventive services, and they are less likely to adhere to necessary treatment. That holds even when the health plans explicitly and publicly exempt preventive services like cancer screenings and vaccinations from the deductibles. Finally, consumers with consumer-directed health plans are not better shoppers. Study after study of consumer-directed health plans has found no evidence whatsoever that these mechanisms, including the transparency tools that go with them, lead to price shopping or to lower prices for key services like office visits and inpatient care. That's really important because the factor that is driving up costs in the private market today is the high price of care, not excess utilization. All in all, simply expanding HSAs and consumer-directed health plans is a costly solution in search of a problem. It won't improve affordability for those who have the most problems paying health bills. It won't improve the efficiency with which Americans use their health care, and it won't contribute to containing health care costs. Thank you.
Thank all 4 of you. I appreciate the perspective. We're the beneficiaries of that, and we'll look forward to exploring further. I'm going to invite Mr. Johnson to inquire.
Thank you, Mr. Chairman. Mr. Ramthun, welcome. In your testimony, you recommended that Congress allow seniors to continue contributing to HSAs and actually stay off of Medicare for longer. As a person ages, they generally cost more to care for. So if HSAs are available to seniors, wouldn't you agree that they can help reduce costs to our Medicare system?
I believe they can absolutely help reduce those costs by staying on a private policy, using their HSA dollars to pay for those expenses rather than have Medicare pay for those expenses, certainly from the first dollar, so absolutely.
Well, keeping in mind that Medicare Trustees report released yesterday, do you see HSAs as being a part of the solution to save Medicare money?
I absolutely think HSAs are part of the solution. We need to be looking at all different options, and HSAs are a very good one to include in that list.
Thank you, sir. I yield back.
Mr. Thompson.
Thank you, Mr. Chairman. Mr. Isles, in your written testimony, you noted that 82% of those plans surveyed offered members health care cost information. Can you expand on what you meant by that, what kind of cost information, and how it's used by the consumer?
Sure, thank you for the question. So most plans that provide HSAs have tools online that their members can go and use to look at the potential range of costs, for example, of going to a particular healthcare provider or a facility. Can give a range if you go to one facility versus another, particularly for those that are in network and where an individual is able to benefit from negotiated lower prices, that individuals can find out, at least at a general level, and sometimes with great specificity too, how much a particular healthcare treatment or service might cost depending upon where it's received. So you can go online, plug in a zip code, plug in a provider, plug in a procedure, and get a range of costs.
Is that somehow juxtaposed with the quality of that procedure?
There's often quality information that's provided at a provider level or a facility level. Obviously, all these tools are different depending upon which plan has developed them, but most of the quality information would allow an individual to compare again, say the outcome of a hip replacement surgery at one facility.
So the 82%, is that what are you measuring there? Is that 82% reflective of quality measurement?
So the 82% is around the transparency of cost and price information.
So it's just the cost side.
Right.
It doesn't necessarily reflect the quality
The quality
side.
information that we found was about 70% had physician-specific quality data and 77% had hospital-specific quality data. So it's not a perfect one-for-one, but overall, there's good information to look at both cost, price, and quality.
Okay, thank you. Dr. Gleed, some of the witnesses have already mentioned that we've watched the volume of HSAs increase dramatically since they were created. But in a 2017 report on employer-sponsored coverage, PricewaterhouseCoopers found that movement to high-deductible health plans loses steam. After shifting health care costs to employees for years, the employers are starting to ease off, and that growth in high-deductible employee-based plans is starting to slow. Can you talk about what might be driving that shift, and how much of that should we attribute to the health care cost curve versus the economy generally?
So thank you for the question. I think it's difficult to decompose where that change is coming from, but I think one of the factors is growing recognition that it is prices and not utilization that is the main factor that's driving up costs today. And unfortunately, although many plans now include cost and quality information transparency tools, the evidence is very clear that people do not use them and do not find them helpful. And so if you actually want to do something around prices, just raising people's deductibles doesn't turn out to be the way to do it. And so we see costs continuing to rise in high deductible plans, and insurers and employers looking in other ways to solve these problems.
And then I'd ask Mr. Isles this: when somebody does use that, the 82%, I guess, is the number, those folks, when they do look at the cost, do they get some sort of idea what quality they're getting for that cost? So
unfortunately, our metrics of quality that are available to be used on these kinds of tools are just not very good, and they're not very credible to most consumers. So in general, when people's doctor tells them where to go for a checkup or something, they follow their doctor's recommendations and not what it says on the tool. And so there really is a limitation to how these are.
Thank you. I yield back.
Ms. Jenkins.
Thank you, Mr. Chairman. Thank you all for being with us this morning. Since the inception of flexible spending arrangements and health savings accounts, millions of Americans each year were using these and other similarly tax-preferred health accounts to help reduce their annual health care spending. However, this consumer access changed with the passage of the Affordable Care Act. Consumers are now required to obtain a prescription for over-the-counter medications in order to be eligible for reimbursement under these accounts. This change, which went into effect January 1st of 2011, severely limits the ability of millions of American families to use funds set aside in their FSAs and HSAs to purchase over-the-counter products such as those for pain management, smoking cessation, and cold and allergy medications. Over-the-counter medications are often the frontline treatment for many common illnesses or for maintenance of chronic diseases and should be treated as medically reimbursable health care therapies, just as prescription medications are. A recent study found that over-the-counter medicines saves the U.S. healthcare system $102 billion every year through cost savings associated with over-the-counter medicines and avoided visits to the doctor. restricting consumers' ability to be reimbursed under FSAs and other tax-preferred accounts imposes an unfair cost increase on individuals and families who are already struggling financially. So that's why I've introduced legislation along with Mr. Kind to restore this benefit called the Restoring Access to Medication Act, and I'm hopeful my colleagues will smile favorably on this legislation soon. According to an April 2014 study by Nielsen, 75% of Americans support changing the law to grant over-the-counter medications tax-preferred preference again. In fact, the Health Choices Coalition, representing physicians, dentists, consumers, retailers, manufacturers, pharmacies, pharmacists, patients, insurers, and employers, large and small, are all in support of restoring this benefit on behalf of millions of Americans. Americans are being asked to fund more of their health care expenses through higher deductibles and copays, so I believe it's more important than ever that cost-effective over-the-counter medicines are treated the same as other eligible medical expenses in tax-preferred health care accounts. I don't know why we should be making it harder for Americans to use their own pre-tax dollars to purchase these everyday health care products. So with that, Mr. Isles, shouldn't Congress be making it easier for people to access these safe and effective over-the-counter medications?
We have been supportive of being able to use HSA, FSA funds towards over-the-counter medications when patients have an option to use something that's over-the-counter, that's a lower cost, potentially not needing to necessarily go and have a physician's office visit. We've been supportive of those kinds of efforts, yes.
Thank you. And on that point, so many Kansas communities face the challenges that come with accessing rural health care. So, Mr. Rathen, do you believe that it makes good public policy sense to require patients, especially rural patients, to seek a doctor's prescription in order to be able to use their tax advantage accounts for medicines that were available over the counter?
Thank you. I believe it makes no good health policy sense to add cost to the system by seeking an additional office visit just to get something that is available over the counter today.
Okay, thank you. I appreciate it. And with that, Mr. Chairman, I yield back.
Mr. Kind.
Thank you, Mr. Chairman. I want to thank the witnesses for coming. So let me just pick up where my colleague, Ms. Jenkins, just left off. And I'm proud to sponsor the Restoring Access to Medicare Act with her. But Mr. Isles, Mr. Anthem, if you hadn't had a chance to take a look at the specifics of that legislation, I encourage you to do so and give us any feedback in case there's something we might be overlooking. And Mr. Anthem, let me start with you. Because Mr. Johnson already cited the recent Medicare trustee report that just came out showing that the solvency of Medicare has been reduced by an additional 3 years. In fact, Washington Post just ran an article in today's paper titled Key Medicare Fund to Run Out Earlier Than Thought. Mr. Chairman, I ask unanimous consent to have that inserted in the record
Without
at this
objection,
time.
so ordered.
Indicating that with the passage of the recently enacted tax cut, there's going to be a serious drop in revenue that's going to affect the Medicare program, along with the repeal of the individual responsibility aspect of the Affordable Care Act. Trustees also cite that there's going to be a huge leap in uninsured and therefore uncompensated care, all of which is going to detrimentally impact the Medicare Trust Fund by reducing solvency by 3 years to 2026 now. Mr. Anthem, you indicated that there might be a role of HSAs to play as far as showing up and bolstering Medicare. What did you have in mind?
That individuals who are still working at age 65 would be able to take Medicare as a secondary payer. Today, I'm self-employed. I must take Medicare as a primary payer. That also applies to workers of small businesses with fewer than 20 employees. So to give those individuals the option to stay on their employer-based coverage and have Medicare pay their bills on the back end rather than the front end.
Allowing them to stay on their...
Yes, sir.
Okay. Well, part of the reason you want to get the younger 65s into Medicare is for risk adjustment and spreading the risk, too. So if you allow more of them just to stay in the private plans, won't that also then jeopardize the long-term solvency and the expense of older and less healthy Medicare patients?
Medicare does not work like private insurance where you're having to spread risk. Medicare pays claims out of trust fund dollars. So if you have fewer people accessing the trust fund dollars, I would think that would save Medicare money.
Well, Ms. Steidel, I think in your testimony you indicated about what the typical HSA participants contributing every year, from about 1,000 to 1,500 or so.
Yes, sir.
Is that correct?
Yes.
That's substantially below the current contribution limits as they exist today. Is that right?
That is correct.
You must have heard Mr. Isles' testimony earlier, and one of the 4 points that he said that one of the things we ought to be considering as a committee is perhaps extending the contribution flexibility and therefore raising those contribution limits. What would your response be to that?
I would absolutely support that. I think that employees should be able, participants in HSA should be able to cover their entire out-of-pocket risk. So there should be parity between the out-of-pocket maximums under the ACA and the contribution limits for health savings accounts.
Regardless of income limits right now on an individual, how much they're earning? Does it matter to you?
It doesn't matter to me, although income limits would be one way of addressing alternatives, right?
Ms. Gleed, you have anything to add?
So I think the concern is that the average of $1,000 includes both people who are funding a lot, putting a lot in their accounts, and those tend to be very high-income people, and people who are putting very little in their accounts. If we raise that contribution limit, it isn't going to affect the people on the bottom. They're already not bound by the contribution limit. Yeah. It's just going to put more money in for the people at the top.
Mr. Rantham, let me ask you too, one of the areas, groups of people who are getting hammered right now are those in the individual market who don't qualify for any premium tax credits because they're earning too much. And yet the premiums are going up and they're just getting smacked. I mean, and you indicated that roughly 10% HSA participants are in that individual market. Is there a way we can, through HSAs, be able to provide some relief to that segment of the 5% of the population who is getting hammered in the individual market?
So some of those individuals already are qualifying for HSA contributions from their employer, so that definitely helps them. By staying in a lower premium plan, they can use some of the premium savings to fund their account as well. Others have suggested using dollars in HSAs to help pay for their premiums, and so that's a provision that's in Congressman Paulson's bill as well as other bills. So those are ways that HSAs could be used to offset those higher costs.
I encourage all of you, as a takeaway today, to keep thinking about how we can better democratize HSAs. I think the problem that many of us have on this side of the dais is that it is weighted to those with more disposable income, those who can afford it, some using it as a tax shelter because they're generally in good plans and they're generally healthier in regards to the population. But how do we make this easier for lower to lower middle income people to be able to get in and find some tax savings and better manage the cost risks that they face today? And with that, Mr. Chairman, I yield back.
Mr. Marchant.
Thank you, Mr. Chairman. Mr. Rantham, I come from a congressional district in Northeast Texas. We've got a very low unemployment rate, well below the national average. And these workers, my constituents, are looking for two things with their hard-earned income: choice in their health care decisions and the ability to plan for their future. This is where HSAs come into play, and I believe that the intent of the creation of the HSAs, and I believe that that was the intent, and would you agree?
Absolutely, that was the intent.
I've reviewed some of the charts that we have been provided, and it shows that folks in my district are right in the what you would call the Goldilocks zone. They either have HSAs or they're looking at them as a possibility for working that into their health plan and their financial plan. With insurance premiums rising, we have got to start looking for answers to address out-of-pocket health care costs and that our constituents face. And one of the most frequent calls that we get from constituent services in our district office is the shockingly high amount of deductible that a normal family faces, even in the best plans. And they're looking for every way that they can to prepare for an emergency where they have to pay those amounts of money. Do you or Mr. Isles, can either of you point to me some specific policy changes that we should be exploring to address this issue and to allow families to use their HSAs in a better way?
So I'll start first. Thank you for the question. I think the first thing is to allow more of your citizens to take advantage of HSAs. It does give them that flexibility to choose the provider that they want. If it's more cost-effective for them to use over-the-counter medicines, so that clearly Mrs. Jenkins' bill is an important policy change that needs to go in there, helping them get better information about the cost and the quality of those services. Would give those individuals more information about how they can find better value for their dollars. So those are two things that I would definitely start with. So, Mr. Isles?
Thank you for the question, too. We agree that any policies to make it easier to access HSAs would be positive. One additional item that I would mention, too, is looking at greater benefit design flexibility to make HSAs even more attractive option to a broader group of individuals. Today, in America, about 60% of individuals have a chronic condition of some form or another, and the limitations on how HSA dollars can be used, for example, for certain types of high-value treatments are limited, and you have to go all the way through your deductible. So policies that would allow individuals to get access to some pre-deductible coverage for high-value services for chronic conditions, we also think would be a positive thing.
Ms. Dottell?
Yes, sir. Thank you also for the question. I think that I would agree strongly with Mr. Isles' comment that I think some of the waning high deductible health plan enrollment that you've seen is because employers are needing to be more concerted efforts with regard to chronic care, chronic illness, and value-based design. And so in some cases, they are providing a high deductible health plan, but it's not HSA qualified because it has some of these other limitations. So certainly expanding access and flexibility for employers in their design of those plans to make them HSA qualified as well would be helpful.
Ms. Gleed?
So I don't think HSAs are going to be the solution to the problems that face the people in your district. I think that what you really want to do is encourage those high deductible plans to lower their deductibles or to provide exactly the kinds of access to chronic disease services that we would like to see. I think plugging that through an HSA and expecting somebody to have a savings account on the side in order to pay for their chronic disease prevention is not the way to solve this problem, and moving in that direction isn't going to help your constituents.
So you would have them have a more expensive plan.
The plan, the cost of the plan will be a function of what people use. Whether they use it out of their HSA, whether they're using more services or not, isn't going to is the key point here. Not whether they're paying for it out of their HSA or not.
I doubt if anyone in my district would agree with that. Thank you,
Mr. Higgins.
Thank you, Mr. Chairman, and thank you for being here. You know, the health savings accounts, you know, are helpful in terms of tax treatment, but really does very little to address the underlying problem, which is the rising cost of health care and the poor quality. I have a very simple premise. I think the private insurance companies, their business model is to screw people. They jack up their premiums, they jack up deductibles, they reduce payouts, and they increase premiums. I think, like anything else in life, particularly with health care and in negotiation, it's all about leverage. And I think the federal government fails to use the significant leverage that it has under its health insurance programs. Prescription drugs, you know, the Department of Defense, the Veterans Administration, Medicaid, they negotiate volume discounts. And according to the Commonwealth Fund, they achieve 25% savings every year. That is wisely, smartly using the leverage that you have. Under the Medicare program, there's 57 million beneficiaries. From 2010 to 2016, the price per patient, per enrollee, cost increased about 1.3% as compared during the same period for private insurance, 3.5%. So I think the federal government needs to do a much better job using its leverage to drive down the cost of health care and drive up the quality. I am particularly concerned about the population between the ages of 50 and 64. They get hammered in terms of health insurance premiums on the exchanges. They are, to this century, what the traditional Medicare population was to the 20th century, and that is that Insurance companies had every opportunity to provide good insurance products for that segment of the population and didn't want to because it wasn't profitable for them to provide insurance that was affordable and good for people that are older and statistically sicker. So now it's 50 to 64 that gets hammered. We have an obligation to try to help them. So, Dr. Gleed, I would ask you, I have a bill that would simply allow those between the ages of 50 and 64 and a half to buy in at their own costs into the Medicare program, which is the insurance. Medicare is fully compliant with the essential benefits of the Affordable Care Act. Why, as a healthcare economist, why in God's name wouldn't the federal government use its leverage to provide, first of all, relief to this segment of the population, of which there's 60 million people? If you divide that by the number of congressional districts, that comes up to 138,000 people per district. And that segment of the population votes. So why aren't we using that leverage to provide, at the very least, relief to a population 50 to 64 and a half that is getting clobbered?
Thank you. Thank you for the question. I commend you for paying attention to this population. I think it is a population that really needs the federal government to be thinking through what are the best ways to address it. And public options might be one of the things that should be on the table in for that population. I think we need to work through the benefits and the costs of a variety of different strategies to address that group, making sure that we maintain the viability of the Medicare program and trying to really figure out what is going to work best, both for that population and I think also for people with lower incomes that are at ages below that. But I think really thinking about the federal government's power to establish prices and to affect prices in the marketplace, not only the exchange marketplaces, but in the healthcare system throughout, I think is really an important direction for policy to take.
And Doctor, I would say this, that the second beneficial effect to allowing people to buy into the Medicare program, it would allow private insurance companies to compete for that more desirable, because of less utilization, that 27 to 50 population, which, you'd have better products that would promote things like healthy lifestyles and prevention, thus creating a healthier future Medicare population. I mean, look, this is not ideological, it's arithmetical. And I think that, we have to take a common sense approach when it comes to health care because the center will not hold. We cannot sustain 7 to 8% annual growth over the next 10 years. Thanks very much. Yield back.
Ms. Black.
Thank you, Mr. Chairman, and I want to thank you for bringing the panel here today to talk about something that we don't talk about often enough, and that is some ideas outside of what the traditional is. And so for 8 years now, everywhere I go in my district, people will tell me stories about how Obamacare's heavy hand has cost them money and has hurt their health care. And in Tennessee, we see the collapse of Obamacare is really having some dire circumstances for our citizens. We see massive premium increases that are making health insurance unaffordable for more and more Tennesseans. And we also see that the rising deductibles are really hurting and making it even harder to get those services when they do pay the high premiums. And so I think that we can't continue to do nothing. We've got to look outside of the box and look to some things that maybe haven't been quite as public as some of the other products that are out there. So we have to continue to work to empower individual families and allow them to make those decisions for themselves based on what best fits their needs, what best fits their wants, and what also best fits their pocketbook or their budget. Now, as a nurse for more than 45 years, I know that a central challenge of reforming the healthcare system is finding policy solutions to lower the cost of health care while also increasing the access to health care. And I think that is part of what this discussion is about today, and I thank you for being here. So while we work toward a permanent solution to bring relief to the American people, these health care savings accounts do empower individuals to be able to invest and use their health care dollars however they best see fit. By expanding these HSAs to cover certain low-cost, high-value services like chronic care services below the deductible, not only can we help those with chronic conditions better manage their care, but we can also save the healthcare system billions of dollars through better medication adherence. And so, the Chronic Disease Management Act of 2018 that I have sponsored with my colleague on the other side of the aisle, Mr. Blumenauer, is a simple bipartisan measure that we introduced. Mr. Isles, I want to start with you. You mentioned in your testimony that covering high-value services can help reduce long-term costs. Can you expand on some of the benefits of allowing that first dollar of coverage for chronic care, both for patients and for the healthcare system overall?
Sure. Thank you for the question, Congresswoman. And we support your legislation. We think it's an important step to improve HSAs to make chronic conditions eligible for pre-deductible services. And as I mentioned, with 60% of Americans having at least one chronic condition, over 40% have two or more. Ways that we can provide some more flexibility to provide access to high-value services. I think one of the best examples, whether it be in the area of diabetes or cardiovascular disease conditions, to be able to provide treatments pre-deductible can have the effect of keeping people healthier longer, preventing them from using much more expensive specialty services, hopefully keep them out of the hospital. Better management, for example, of blood glucose levels over time could definitely lead to better outcomes for patients with diabetes and making the healthcare system more efficient and keeping them out of higher cost areas. So we're very supportive of trying to provide access to those types of services that are proven to work, that have strong evidence that we know really do have an impact on the lives of patients and the overall healthcare system and costs.
Well, I thank you for that. I can tell you as a visiting nurse, when I would go see my patients and they had diabetes and I would take their blood sugar and we would see that it would be elevated and I'd say, are you using your medication? They said, well, I'm just using half of it because I don't have a whole lot left. So I'm saving some for tomorrow or the next day. I said, it doesn't exactly work that way. But I appreciate your comments and appreciate the fact that you do support our measure. Thank you, and I yield back.
Ms. Chu.
Dr. Gleed, I'd like to ask you about the HSAs as it pertains to women. In your written testimony, you mentioned that one concern with the high deductible health plans and HSAs is that in practice, these plans haven't reduced the burden of out-of-pocket costs for consumers. Although the lower premiums can make insurance seem more affordable, these plans rely on consumers' ability to plan for medical emergencies, which often can't be predicted. So then, let's talk about women and pregnancy and their out-of-pocket costs. Because 9-month pregnancies often span 2 plan years, women would have to hit their plan's deductibles twice within the course of a single pregnancy. And if a woman has one of these plans when she gives birth, she could, depending on the complications, face over $20,000 in out-of-pocket costs under high deductible health plans. Even if a family has been dutifully saving for the arrival of a new child, medical complications can put the child's birth well outside the scope of the family's savings. Another unforeseen cost that often shocks new mothers occurs when the mother receives care from an anesthesiologist who is out of the plan's network during delivery. The mother, of course, most often has no control over which anesthesiologist is available to care for her. It's unreasonable to assume that she would be shopping for an anesthesiologist while she's in the delivery room giving birth. And even if the hospital and OBGYN are in network, the anesthesiologist might not be. While being served by an out-of-network doctor is a pervasive issue amongst many types of plans, it's particularly impactful to those who have high deductible plans because they're charged with higher out-of-pocket costs than those with other health plans. So can you discuss how these high deductible health plans shift the cost to a consumer, especially in the case of an unexpected medical cost like a complicated pregnancy?
Thank you very much. I think that is exactly the problem with high deductible health plans, which is that even if we exempt various services out the bottom end, people who actually have something wrong with them or really need costly services, like pregnant women, are going to be the ones who wind up paying a lot of money out of pocket. And very, very few people have enough money in their health savings accounts, and virtually no middle-income people have enough money in their health savings accounts to pay those deductibles for an expense like pregnancy. That's just not a realistic expectation. The second point you made about seeing an out-of-network anesthesiologist points to the big problem with thinking about using transparency tools and quality tools of the type that we're offering to get people to shop. There is a real limit to how much shopping we can plausibly expect happens in the healthcare system. When you are lying on that table, you are not checking your phone to see which anesthesiologist is in network. And that is just not a good way to build a healthcare system.
In fact, given the fact that half of all births in the U.S. are unplanned, it seems to me that these consumer-directed health plans would leave a number of families behind when it comes to the birth of a child. So, Dr. Glee, would you say that these types of health plans are adequate substitutes for comprehensive health coverage?
Absolutely not. And there is no evidence at all that providing an HSA on top of a high-deductible health plan undoes that difference. In fact, that's the whole point of a high-deductible health plan.
And let me ask about prescription drugs, because right now, $1 out of every $6 spent on healthcare in this country is spent on prescription drugs. But a recent study by the Pharmacy Benefits Consultants found that over the past 14 months, 20 prescription drugs have been seeing price increases of over 200%. So do these plans do anything to address the skyrocketing underlying price of these drugs?
I don't think there's any evidence to suggest that they do any more than any other plans do to reduce the price of those drugs. If the only thing that they really do is shift more of that cost onto the patients who need the drugs.
Thank you. I yield back.
Mr. Paulson.
Thank you, Mr. Chairman, and for holding the hearing. This has actually been really instructive testimony today. Look, I mean, we already know that healthcare savings accounts are becoming more and more popular. It's at least 22 million Americans are using these. A lot of Minnesotans actually are using healthcare savings accounts. And that average income level, the folks that are using them, is less than $60,000. So these are middle-income folks, average middle-class Americans that are actually interested in making sure they're using their own healthcare dollars for their own healthcare needs. You talked a little bit about some of the incentives that are needed, and some of us have legislation to actually have more incentives to use HSAs and giving some more flexibility, limitations, removing limitations for those who may have chronic conditions. I want to ask one other question regarding this concept of direct primary care that has become more and more popular, that I'm hearing from primary physicians, family physicians, actually now a lot of employers whose employees are using this model where they do a monthly or a quarterly subscription with a primary physician, and then they have that doctor-patient relationship where they can see them as often as they want and really have that close connectivity, which has been lost, unfortunately, in a lot of reforms in healthcare recently. So Representative Blumenauer and I have introduced legislation together, so the bipartisan component of allowing an HSA to reimburse or to cover that expense for direct primary care. And I'm wondering maybe if you can, maybe Mr. Rantham, if you can just talk a little bit about what is it that makes these direct primary care arrangements more and more popular among individuals and employers and unions for that matter, and why should HSAs be a component of that? Elaborate on that.
Thank you, Congressman Paulson. I think people are looking for lack of a better term, a medical home, a relationship with a physician, which seems to be increasingly challenged these days. Many physicians are retiring. We've seen many urgent and retail clinics pop up in their place where it's convenient to get health care. It may be even more cost effective, but our primary care physician has retired and we're looking for somebody else. So I think we need to recognize that these relationships are changing between patients and their physicians, and not everybody pays on a fee-for-service basis anymore. So HSAs are not currently flexible enough to allow those types of relationships to be paid from an HSA, and in fact, we believe that the coverage, if you will, that relationship between the doctor and the patient actually cancels their HSA eligibility even when they're enrolled in the right type of health insurance plan. So your bill addresses that and would go a long way to helping those people out.
Maybe, Mr. Isles, maybe you can explain, I mean, some of your members, as an example, would they see this as a similar flexible arrangement that would serve a need in the population similar to chronic care?
I think many of our members have been very focused on ways to enhance access to primary care. I think the benefits of having a relationship with a primary care provider are very well known, and trying to make sure that that relationship is close so that there can be care coordination, so that there can be ongoing treatment, I think is a very positive step. We want to make sure that that relationship, that there aren't barriers to having good relationships with primary care physicians. And so things that support primary care relationships to make sure that people get access to lower cost care, to get continuity of care are generally viewed as positive things.
Yeah, thank you. And Mr. Anthony, you can offer a quick comment, but I think as we've had this discussion here, as we've had over the years, of course, is there are a lot of reasons why healthcare costs are high, and they've been a challenge for families and individuals and small businesses. But one of the biggest contributing factors is that consumers tend to be disconnected from their healthcare spending. And there's usually, an insurer that's acting as that middle person between the patient and often the cost of the service, and figuring out how much something actually costs can be a challenge in healthcare. Would you agree or disagree that, HSAs are actually a good tool to help reduce costs in our current system right now?
I believe they're a good tool, even though others may disagree. I certainly pay a lot more attention to what things cost. Sometimes I don't know that in advance, and I find out after the fact, and I wished I had known and was able to ask other questions like, do I even need that? Because I might have decided differently. I do think that we have a long way to go in our healthcare system as to making consumers aware of those differences, the quality that sometimes is inversely related to the cost of the care. So we're making headway, but everybody has these challenges. It's not something that's unique to HSA qualified plans. Those individuals are most financially impacted by doing so, though.
And Mr. Chairman, I think in having the hearing today, I think there's a recognition that this is not some silver bullet magic answer to solve all these challenges, but this is clearly a piece of the puzzle that can make a big difference for consumers. I yield back.
Thank you. Mr. Kelly.
Thank you, Chairman. Thank you all for being here. First of all, I just want to approach this from a little different place, because I actually own a business. I'm an automobile dealer, and we do buy health insurance for the people that we work with our associates. So I think sometimes you can debate this stuff and keep talking about it, but unless you're actually on the field doing it, it's a little bit different, because people have these ideas. I read a study that said this doesn't work. So I do know that for people who own their own businesses and they want to take care of the people they work with every day to come up with mutual success is the way we have to go. And I think, Mr. Blumenauer, I didn't realize you're on all these bills. You're a champion. You're a champion. I knew that already, but Earl and I have a bill called the Bipartisan HSA Improvement Act that reduces barriers, expands access, and makes health care more affordable. And this common sense bill has been already endorsed by 60 organizations. But I want to go with it not from what the notes that I have here, because I've been listening to everybody and I get it. But I want some of you to weigh in on something right now. Because it's my belief, and some of you are in my age group, but there used to be an advertisement on TV, and it was for Fram oil filters. And you remember the guy holding the filter? And he would say, you can pay me now or you can pay me later. Meaning, if you change the oil in your car, your truck, and you change the filter, that truck or car is going to run a lot better, a lot more economical. I think it's the same thing with people. And so I wonder all the time as we look at what's happening as a society. Preventative maintenance is probably the cure, or one of the cures, to making sure we have a more healthy communities and a population. So I look at this, and I just am trying to figure out if you could all weigh in on this, because I think HSAs are the way to go. I think when you allow people to do what they want to do with their own money and make it available to them to do something ahead of time with pre-tax money, they're going to make decisions that make sense for them. And people who would say they don't really look at it that way, I would just say, you got to come home with me and look at the 56 people that work at our dealership right now, and they make really smart decisions, especially when it's their money. So I think the HSAs, while not the cure-all, and I know it's not, but also we have a piece for the healthcare sharing ministries, for people, the faith-based people who really believe that helping each other kind of goes back to the basics of who we are. But if you can each weigh in a little bit, this idea that if we're going to look at this, because a lot of people right now, I got to tell you, we paid almost $600,000 this year for our insurance. It's for 56 of 127 people that we work with every day. Now, they have an insurance card, but they have very little coverage, and that's because in order to keep it at 600 grand, we had to do things with deductibles and copays. And now we're trying to come up with a way, how do we help them with their copays? How do we help them with their deductibles? How do we do that? HSAs are a way to do that, those pre-tax dollars. But I want to get to wellness programs, and in addition with health, with exercise, we need to start looking at nutrition too, because part of wellness is eating right to begin with. So each you can weigh in. How could that fit in, besides the HSAs and allowing people to make common sense decisions for their own health every day and for their families, which I believe mothers and fathers do? Just give us a little bit of a flavor of that, because I know it's not the cure-all for everything, but it's got to be incredibly important. This preventative maintenance is incredibly important.
Well, I will start. Thank you for the question. I believe employers are starting to recognize that we need to look at employees' health more holistically. And so some of them are using incentive-based programs. Some are tied to HSA, some are not, to encourage their employees to lead healthier lifestyles so that these costs are reduced down the long term. I think Ms. Dietl and Mr. Isles can talk about some of these specific programs that they are aware of where employers have done just that.
Okay.
Sure. So thank you for the question. And we, too, have supported your legislation. We've signed on to a letter that recommends that this bill be enacted because it's a very positive step. We agree that providing more access to preventive care and treatment and services, whether it be through innovative wellness programs, through telemedicine, and being able to provide access to lower cost care that's more convenient, to your point, that gets to the right care at the right time, especially when it's done earlier, can offset the need for much more expensive treatments and services down the road, and we're very supportive of those efforts.
Yes, Congressman, thank you for the question. It's important to recognize that the Affordable Care Act for both high-deductible health plans and other coverage requires first-dollar preventive services. So I think that the issue is really for better communication to participants that they have access to these services already. I think that's one critical component, at least in working with our clients, that we help them communicate more effectively their plans. But I think also to my colleagues' points here, employers are trying all sorts of innovative things. They want to, as we've discussed, value-based design, they want to help people with chronic conditions be healthier. They want to provide wellness incentives. And again, I think this is communicating and sometimes, unfortunately, the people who are going to commit to wellness efforts are people that already go to the gym and already eat right and those kinds of things. So
we got to get more people on board.
It's helping those that need those chronic illnesses move forward.
Just one thing. I know my time's up, but honestly, we always talk about the cost of doing this and how it's going to affect our tax revenue. I'd like somebody to do a study on the cost of not doing it, what we're doing to our total population, and long range. You can pay me now or pay me later. I think we're reaching a point right now where there's no such thing. The dollar amount is so crazy. If we don't get people healthier early on, we have great, great problems. So thank you all for being here. Chairman, thank you for allowing me to go over. And Earl,
Mr. Blumenauer,
thanks for being on everything.
Thank you, Mr. Kelly. Well, I do think that we have mechanisms now with health savings accounts that have been embraced by a variety of people for a variety of reasons. I appreciate some of the cautionary notes about how are we getting the maximum impact for health care with them. And I think those are valid, and I think we ought not to just rush in to wildly increase limits and not look at the consequences. I think program design is very, very important, and I think there's common ground here. We can do things, and Ms. Black and I have been harassing people about this for a number of years, and I think it makes, with good research out of Michigan, that makes sense. One other item that I've been working with Mr. Paulson on deals with the arbitrary definition of direct primary care, that it somehow is a whole new health plan. You know, and some people have taken advantage. You know, dismissively, it is called concierge service. But I've had interesting experience with a physician who simply doesn't take insurance, but he's able to provide very intense personal attention because he's not dealing with all the overhead and whatnot. It's not for everybody, but it has an important role. But it was interesting to me to find out that that doesn't qualify for participation in the program. Beyond that, I was, I can take that, life goes on, but to find out that they couldn't undertake the direct primary care for employers who for a nominal sum, $50, $100 a year or something like that, be able to provide that personal connection, and that it would be deemed that somehow it was a different health care program, and they were denied. And so I think this would have nominal impact on the overall cost, but it would have significant impact in terms of being able to use an innovative approach that I have no doubt in my mind would reduce overall health care expenses and improve outcomes for patients and doctors who are on the assembly line. Every 11 minutes, there's a new patient coming in. And there's so much churn, inefficiency. It's not the best care. It's hard on patients, but it complies with rules of the road. So I would respectfully suggest that we ought to move forward with a package of some of these things that are not controversial, that don't depend on whether or not we're going to have the Affordable Care Act. We don't have to blow up Obamacare to be able to move forward with these. And we don't have to open the floodgates to more and more benefits for people who may not need it. But more to the point, it wouldn't be the most efficient way of allocating scarce dollars, because someday we're going to get back to thinking about allocating scarce dollars after we've spent trillions of dollars here at this dais in a matter of minutes. This is something that can bring us together. I would, just for the record, Mr. Chairman, I would like to submit a statement for one other thing that speaks to Mr. Kelly's big picture item, and we've had a lot of fun talking about things like that. One of the big picture items that concerns me is that we've had 293 hearings since your team's been in charge. We have had 5 minutes devoted to infrastructure finance. And this has serious health implications for our nation. Having infrastructure that's falling apart as we fall behind, it's not just traffic safety, it's water quality. There are any number of areas, air pollution. And if we actually maybe spent a week or two listening to certified smart people, starting with the U.S. Chamber of Commerce and the AFL-CIO and the Truckers Association, head of the Automobile Dealers Association, engineers, local government, we could talk about what would happen if our committee met our responsibility dealing with infrastructure finance, which would have dramatic health care consequences, not just creating millions of family wage jobs, but actually improving air quality, water quality, traffic safety, that would make a difference for health care in this country. So I would just like to submit a statement to the record, hoping that we will, I like this hearing, I enjoy what we're talking about, hope we can move forward, but I hope we can find more than 5 minutes to talk about a threat to our nation's health with the decline of infrastructure. Thank you, I appreciate it.
Good segue. Ms. Sewell.
Thank you, Mr. Chairman, and I want to thank our witnesses today. I have a doctor in my state, Dr. John Waits, who runs the only rural family medicine residency in my state. He grew up in a conservative household and interned at a think tank in 1993 where he fought Democratic health care reform efforts. He studied medicine, thinking he would serve as a missionary abroad, but instead he found himself at a hospital in a rural part of Alabama, Centerville, and he runs the only family medicine practice there. He told my office before that he realized quickly that he had a lot of patients who were underemployed, without a vehicle, chronically ill, or food insecure, and that these Americans would reap benefits if they had the money to put in these tax-free savings accounts. But that money was non-existent for lots and lots of these patients. He often says that he remembers realizing 2 weeks into his post-residency that he hadn't met a single patient for whom a health savings account would solve anything. Mr. Chairman, I ask for unanimous consent to submit this article in the record about my district and Mr. Waits, Dr. Waits. It's called "The Healthcare System is Leaving Behind the Southern Black Belt."
Without objection, so ordered.
I've placed this article in the record before, and I will continue to do so because I think it's important that we address solutions, acknowledging that healthcare is not a one-size-fits-all, but acknowledging that there are differences between urban areas, suburban areas, and rural areas. I agree with Dr. Waits, who likes HSAs, and I'm not opponent to it. I just don't see it as a cure-all. I don't even see it as helping to address the underlying problem, which is the escalating cost of health care, when so many of my constituents can't afford to save in their 401k, let alone save money through the health savings accounts. So in the 11 counties of my district, the average median household income is $28,000. And I know that you, Ms. Deitel, talked about median income being around $58,000. Well, my district is way below that. And here's the rub. I'm a proud product of my district. I'm a product of my district that through education had other opportunities. And I had a chance to work in a really great law firm that offered me a health savings account, which I did participate in. But the reality is that the majority of the folks that I represent in my district don't have that same, can't make that same choice. And in fact, I get a little upset when I think that people view folks that I represent as not being personally responsible for their health care because they can't afford to save in these health savings accounts. It's just the flip of that, frankly. These are people who are struggling every day to put food on the table for their children, to provide better opportunities for their children, who want preventive medicine, who want better access to health care. So many of them don't even have transportation to the nearest health care provider. And I would agree with my colleague, Earl Blumenauer, that we do need to talk about infrastructure financing because telehealth can't come to parts of my district in rural Alabama because we don't have broadband. So there are real issues about health care that we in this committee address. And in fact, I am on the bill that Mr. Kelly and Mr. Blumenauer, the bipartisan bill about improving HSA, the health savings accounts. So to the extent that we're going to have them, I do believe we need to have reform. I guess my question is to you, Ms. Glad. I want to make sure that we are addressing the real problem, which is access to health care, the rising cost of health care, and making sure that we in America, the land of the plenty, actually do have health care that can reach every part of America, irrespective of one's ability to pay.
I couldn't agree with you more. I think your point is exactly correct. We need to think about how to direct our tax dollars to the people who are going to need that the most. As we think about reforming HSAs, I think what that should help us to think about is to, as Representative Blumenauer pointed out, making the design of these changes as targeted as possible to exactly the problems we think that we need to address. So, for example, perhaps chronic disease management, but opening them up a lot just means sending a lot of tax dollars to people who really don't have these problems, and that means tax dollars that are not available to provide care to people who do.
And listen, I would love if you, Ms. Deitel, would work with my staff to figure out the statistics in my district in terms of median income and their ability to use HSAs. Like I said, I'm not against that. I just think that at the end of the day, there are a whole host of reasons that go into the rising costs of health care, and I don't think that health savings accounts actually gets to the problem that really, which is access to health care and the cost of health care for folks that I represent. Will you commit to helping my...
Absolutely. In fact, we had a meeting with your staff yesterday.
But I think that your numbers are contradictory to the what...
And we were going to follow up with your specific information, and we discussed ways to expand it. For example, Healthy Indiana would be a great solution for your district as well.
Okay. Thank you.
Thank you. Look, on behalf of the subcommittee, thank you for your testimony today. Just to put this in a little bit of a context for you as witnesses, this subcommittee on a bipartisan basis has taken on a task of inquiring of healthcare providers, what are the regulations that don't make any sense and that make things more expensive for you to deliver health care? And we've done a series of roundtable discussions. We've gotten 500 submissions from healthcare providers, and it's been a fascinating discussion. And it's one that has sort of transcended some of the normal political dialogue on healthcare. So it's not as if we're only evaluating HSAs as a remedy here, but there is very much a tapestry that we're trying to put together. So I just have a number of questions in closing. Dr. Gleed, I'm getting a mixed message from you. So on the one hand, you've been harshly critical, I think, of HSAs, and on the other hand, you were a little bit complimentary of them. Is the system better off without HSAs in your view, or what's the role?
What HSAs are the question is not whether the system is better off. On the whole, HSAs are going to make the healthcare system spend a little bit more money than it would without if there were high deductible plans without HSAs. And a concern is that making HSAs more available actually just increases the enthusiasm for high deductible plans, which I think are bad for a lot of people. So the challenge is not about HSAs, though. The challenge is really whether we want to give tax breaks to HSAs. That's really the question. People could have HSAs anyway. They could open their own savings account.
Right, for sure. Okay.
So the question is, where should the tax money go?
Right. Okay, I got it. That's clear to me. So the enthusiasm for high deductible plans. The enthusiasm for high deductible plans, Mr. Isles, doesn't come in a vacuum. It's not as if people just say, oh, I want to spend more money on the front end. What is the benefit of this? So in other words, the context is a lower premium, right?
Oh, absolutely, right. I mean, it's all about trade-offs. We can either have lower premiums and maybe have a consumer-directed health plan with an HSA attached to it, or we could have plans that are much more expensive that might cover more, as Mr. Rantham was talking about, a higher actuarial value. It's all about trade-offs, and where we're supportive of is making sure that people have access to some of these tax-preferred mechanisms to offset the impact of some of the deductibles that perhaps they're facing, and do it in a way that also provides greater flexibility, greater choice, greater convenience for consumers who want to spend their own healthcare dollars.
So it's connected to a benefit. It's a level of discipline and so forth that yields a benefit in terms of a lower premium.
That's right. I mean, as we've looked at the premiums for a typical HSA plan or eligible plan versus, say, a traditional PPO, it's probably about 10 to 15% less being in an HSA plan. And we're talking about in the individual market or in the small group market, right? There's one common risk pool, at least in terms of how ratings get set. But these plans can be less expensive, and they also provide benefits to consumers who can use those dollars.
I understand. Mr. Rantham, you walked in your opening testimony and in your statement, you spoke about actuarial value. Can you first of all describe what that is? And then that 80% figure, how is that, did you pull that out of the air? But first of all, describe what it is that you're proposing.
So if you think of actuarial value as a overall measure, like the metal tiers in the Affordable Care Act offer.
The value of a policy.
Value of the policy, how rich of benefit coverage is there? Does it pay 70% of the cost on average, 80%, 60%? We know those as bronze, silver, and gold plans today. What it avoids is some of the details of these plan design features and saying it must look like this, it must look like that in order to qualify, which is what we have today. So the design gives you more flexibility for plans to address all of the concerns that have been raised here at the committee level, and do it in a way where the choice can be made by the consumer. Do I want to be in that plan, or do I want a different flavor of that? I don't think we want to make necessarily every plan, a plan that covers 100% of your costs. Should those people have HSAs too? Probably not. They're not available to those individuals in the marketplace today. Probably not the best place for us to start. But this could go a long way to freeing up some of the challenges that everybody has mentioned today, more on a laundry list of challenges.
It's sort of interesting because there's a theme that's consistent with this regulatory relief project, and the theme is this. When you pose the question on regulatory relief, you invite a different discussion. The new discussion is one person's burdensome regulation is another person's patient protection. Okay, that's a rational discussion. We can navigate through that based on good science and good data and so forth. And what you're suggesting here is you can dial these attributes up, you can dial them back, but to observe HSAs in a vacuum, only in the context of high deductible, is not to recognize the benefit of a lower premium and what a lower premium means to families across the spectrum. Okay, Ms. Dietl, question for you. Listening to Dr. Gleed, my interpretation of her criticism was, hey, this is really, I mean, I think the subtext of her argument was, this really benefits people that don't need a benefit. This benefits wealthier people. And yet you're communicating $56,100 income level. That strikes me as modest in the great scheme of things. Where, can you reconcile that? Who is it that you're finding is using these plans and benefiting from these plans? Because from my point of view, that's not uber wealth. I mean, that's not even particularly affluent, $56,100. Can you just walk us through?
Sure.
That?
So we came up with the household income data by appending the data with geocoded data, much like mortgage lenders do. And so I think it is statistically valid. We've actually met with Joint Committee on Taxation, IRS, Treasury folks, Office of OMB and NEC on the same data. And I think that we're working hard, and Roy and I have been on this effort too, to try and help understand the differences between IRS data and our data that's prevalent in the marketplace. I think the other thing we've seen is that as we've studied the data, particularly over the last 10 years, with the rapid expansion of high deductible health plans that are HSA qualified, I think that we've seen those average incomes, median household incomes, come down rapidly. I remember first walking the Hill in 2009, and we were sitting at more like $88,000 for a median household income for an HSA account holder. So I think that it is much more of a rank and file plan. I also think one important point to remember is that the average deductible of any health plan in America is higher than the statutory minimum deductible right now, and that's in my written testimony. And so high deductible health plans have inherent problems, much of which I agree with Ms. Gleed. I think that health savings accounts, though, particularly since the Affordable Care Act is built on the employer system, 170 million Americans get their coverage through the employer market. And if on the ACA side, we believe that a family of four making upwards of $105,000 need premium subsidies and cost-sharing support, why would we remove the only safety net or the only tool that working Americans have through these consumer-directed benefit accounts to provide them with, help for these out-of-pocket costs? Much work to do. We'll be happy to continue to help.
Are you communicating some of that information to the Joint Committee on Taxation and so forth?
Sir.
Because you're on the front lines. It's no surprise to us to hear that the counters here, or these entities that are charged with giving us information are behind the curve. I mean, they just don't have access to the same type of data. So, are you sharing that information now with Joint Committee on Taxation and so forth?
Yes, sir.
Okay, that's helpful because I think that will help inform the debate all the way around. Do you have an opinion about and this would be this notion of expanding first dollar coverage and its impact on premiums? What happens if first dollar coverage is expanded? Mr. Isles?
We haven't done specific actuarial modeling, but I think the types of services that we're talking about would not have a significant impact on premiums. We're really talking about high-value services that we think over time would enable people to stay healthier and probably have lower trend over time. But we're not talking about all of a sudden opening up the floodgates to all types of treatments and services to be covered pre-deductible. That would have a significant impact on premiums. We're really talking much more targeted efforts.
Okay, I think that this has been a very fruitful discussion in my view, and I am sensing some body language from my friend from Michigan. Am I sensing any body language?
I'd like to.
Here.
It's hidden.
Gentleman's recognized.
Thanks. I'm sorry I missed most of the earlier discussion. I was at the Bobby Kennedy 50-year memorial. But, you know, in a sense, I arrived and it's more or less the same old debate. The same old assumptions. And I think we need to talk through these assumptions. Mr. Kelly talks about health care, but it's different than any other product. And the knowledge of people about health care is more complicated than it is buying lots of other things. I think people have to take better care of themselves. That's very true. But other countries have learned, and I think this country has learned, that purchasing health care is a much deeper challenge, and the ability to be knowledgeable is more difficult. And we've worked hard to get prevention into health care, sometimes over the opposition of people on the other side. When you eliminate the individual mandate and you have HSAs more and more prevalent, you're essentially going to raise the cost of insurance for everybody else. The healthier people are going to buy policies that take more risk because they're younger in most cases and they think it's fine. And we were headed more and more in that direction, and we decided we needed to do what every other country did, and that is to really increasingly make insurance available. And there have been efforts to tear it down, and so far those efforts are a major cause of the increase in premiums. It's not the only. So I want to enter into the record, if I might, two things. First of all, my opening statement.
Without
Mr.
objection.
Chairman. Secondly, a document that has been prepared by the Ways and Means staff that shows in terms of HSAs, 81% of the tax benefit goes to the top 8.7% of account holders. And so when you talk about averages, it's important that we really look at the impact in terms of the taxation and the tax benefits. And I think the concern of most of us is not opposition to HSAs under any circumstance, but the essential movement towards more when steps are being taken to provide health care insurance to fewer. And that's what's happening in this country. People who were covered by ACA now are it's more difficult for them to access it. So we had this remarkable increase in the percentage of people having health care insurance in this country. Remarkable. Not good enough, but we're working in the opposite direction now. And so I think we need to have this full, forthright discussion, and essentially we've passed health legislation, and there hasn't been enough adequate discussion about where this country's going. So I want to enter this into the record.
Objection.
And I'm sorry I missed earlier, but the staff will bring me up to date. And Mr. Chairman, I think at the very least what these hearings do indicate is the need to really dig more deeply. And I just want to join Mr. Blumenauer. Though you don't see most people the relationship between infrastructure and healthcare, they are somewhat interconnected. And I just hope that this committee will step up to the plate when it comes to both healthcare reform further and infrastructure. With that, I yield back, having 1 second left.
Thank you very much. I think there are many themes that bring us together. There's differences that you hear among us. I think the good news for you, Mr. Levin, is that Ms. Dietl's information, I think, is going to update the Joint Committee on Taxation, which is what I assume that document was built on, that was just made part of the record. So the proof will be, you know, it either will or it won't. But my sense is she's the canary in the coal mine, and I think is going to have a much better sense, notwithstanding the admonitions from from Dr. Gleed right now. But I think that's actually true. I think that there's a real opportunity for us to work together on this, and the notion that people have just more, you know, an insurance card. I'll go back to Mr. Kelly's point. An insurance card alone does not yield coverage. And I think what we're all trying to do is to get around these areas so that more people are more satisfied with better coverage and more choices than ever before. And so I know that there's a number of other folks that will have some input on this. I ask unanimous consent to submit a statement for the record from the Alliance of Healthcare Sharing Ministries. Without objection, that's ordered. And again, members are reminded that they've got 2 weeks to submit written questions that can be answered later in writing, and those questions and answers would be made part of the formal record. Again, thank you to the witnesses for your time today. The committee stands adjourned.